Good afternoon, everyone, and welcome. Thank you for joining us today for the National Hispanic Medical Association's Intersectionality in Our Communities Support HIV Care webinar. My name is Ashanda St. John, representing NHMA as a previous Leadership Development Fellow and chair of the OBGYN department at Health Alliance Hospitals. I will be your moderator today. NHMA is a proud partner of the Let's Stop HIV Together campaign. Their team supports partnerships to disseminate CDC's Let's Stop HIV Together campaign materials with digital and social media platforms. You might also find them disseminating together campaign materials, messaging, and other CDC resources that support HIV prevention at in-person and virtual events. Now, the National Hispanic Medical Association will share clinical tools and resources with you at the end of this webinar. These materials are available for free shipping if you request materials through their website, or it can be downloaded at the end of the webinar for personal use. NHMA empowers Hispanic providers and physicians to lead efforts to improve the health of Hispanic and underserved populations. So thank you for joining us today. So we're just going to start off with some housekeeping rules. All participants' microphones will be muted, but please feel free to type your questions in the Q&A box for the panelists to address after the presentations. We encourage everyone to join the conversation. We want to hear everyone's voice, and we feel that their voices are powerful. The recording and the slides will be available on nhmamd.org and will be sent out after the event. So let's get started. All right, today we are joined in a roundtable panel discussion with Dr. Lucille Torres-Deas. She is an associate professor of internal medicine at Columbia University Irving Medical Center, and she is also a former fellow of the National Hispanic Medical Association. So we are so happy to have you here, Dr. Diaz-Torres. In addition to that, we have Mr. Carlos Flores Martínez. He is an HIV programs director at the Caribbean Women's Health Association, which focuses on expanding community health work and planning citywide efforts to execute HIV prevention programs and activity. And lastly, joining us a little bit into the presentation is Dr. Valeria Cantos. She is a professor at Emory University, Division of Infectious Disease, and also an internal medicine specialist. And she has focused her research efforts on HIV prevention in the Latinx youth living in Southern United States. So we are so happy to have our very esteemed panelists joining us today. So I'm going to open the floor for everyone to personally introduce themselves to our audience and let us hear more about the work that they're doing and what has paved their passion for infectious disease education and the intersection of identities, and also for those seeking comprehensive HIV care for patients. So welcome you all, and please come off mute and introduce yourselves.
Go ahead, Carlos.
All right, thank you. Hi, everyone. Thank you for having me here, also to be the panelist. My name is Carlos Flores Martinez. I'm the HIV program director at Caribbean Women's Health Association. My career and my passions for the HIV prevention, education, and services to the entire community has been like for over like 20 years since I started doing this job back to my home country, which is Honduras, and I started working for the LGBT civil rights. But then eventually I was getting involved to the HIV prevention education, which also was part of the minorities in my home country. And I started develop this kind of love for all those people that they really need a voice to advocate for them. So now I'm here in New York doing this job, and I expected to keep doing this for the rest of my life.
Well, Carlos, listen, I really commend you on 20 years of service to others and working in our communities and making sure that we uplift the voices of the Latinx community. So I thank you, Carlos, and thank you for joining us today. Dr. Torres-Deas, please give us your introduction.
Hello. Yeah. So I'm Lucy Torres-Deas, and I guess I always start off with I was born in Puerto Rico. I grew up in Orlando with parents from humble beginnings and experiencing healthcare and discrimination and all these barriers early on. It really motivated me to become a physician. And without my parents sacrificing, right, for me, I wouldn't be where I'm at. And so I use this voice now of being a physician, a voice of power, to be at the table, to speak for those who can't speak for themselves, and really try to advocate and message in terms of the barriers that they are facing and how do we really tackle it with them, right? Not just individually. And being a primary care physician, I work in the clinic, in the community in Washington Heights. I've been here for almost 10 years. And it's really seeing the day in and day out what happens to my patients. When I walk through the neighborhood, when I eat there, or even when I have an encounter with them. And I'm a generalist, right? So I'm all about prevention and education. And then doing the NHMA fellowship is in terms of honing in the tools for advocacy and being a part of it. I was connected with the Latino Commission on AIDS, and they provided more information in terms of how we should educate our community because of the disparities and the increasing rise in terms of being the number 2 now in terms of the diagnosis of HIV. And then lastly, the most motivating part, most recently in terms of tackling HIV, is that diagnosing one of my patients. It was one of the hardest things I had to work with her to get through because it was really unexpected. But it was about meeting her where she was at and trying to navigate all the different obstacles and barriers, and then getting her treatment. So that's one of the motivating factors now really pushing me to educate and reduce stigma on this disease.
Thank you both for all that you do. And we understand and recognize that you both are two pillars in the community who have dedicated your lives to service. And I think that when we look at this through a lens of prevention and screening, I can't help but reflect on my own experiences being an obstetrician gynecologist. Fortunately, in New York, we are mandated to have HIV screening for all pregnant persons twice during their prenatal course. And I think it also helps me reflect to the first time I had to bring forth that diagnosis to a patient, and working in Washington Heights as well, and understanding how that can really kind of fracture one's well-being, but also understanding that there's support out there and that there's so many individuals like yourselves who want to provide that cultural congruency of care and how that impacts a patient when you look at it from a patient-centered approach. So I am honored to be on this stage with both of you today, and thank you for all that you do. So let's dive into some of the questions that we really want to explore during this conversation. So the Hispanic and Latinx patient population represents a diverse group of people with a wide range of cultural experiences and racial ethnic backgrounds. How might reducing patient experiences to one group become a challenge to cultural congruency and clinically, see, this is like a little bit of a tongue twister, clinically coordinated care? So please dive in and give us your responses.
The one thing about our beautiful culture, the Latino culture and community, is that we are so mixed in terms of we come from Hispanic descendants, Tainos, possibly indigenous, and African American. And those aspects intersect, and sometimes there's maybe more racism in one versus the other compared to the color of the skin and what country you're from. And within that, right, so there's so many dynamics with that. Then there could be the language component that maybe not everybody speaks Spanish, or Spanish, the dialect is different, or they speak an indigenous language. And so there's so many nuances. So we could have a broad understanding, but if we just provide care and say one fits all, then we really may miss the mark in terms of taking care of this patient and making a connection, and with the community too, that specific one. So it's really having an understanding of that, but then really knowing the individual in the community. And my expertise is integrating health justice into the biopsychosocial spiritual model. So knowing the bio, the psycho, the social, and the spiritual, and understanding those different intersectionalities and how you may tailor your treatment plan and connection with that patient or the community.
And I can so appreciate that. And I think one other element, which I know you do so well, is doing that with a step of respectfulness, right? And so kind of understanding and entering a difficult diagnosis or a difficult conversation, and we kind of label these as complex conversations that we have, whether it be screening, prevention, or even if our patients are diagnosed with HIV, right? And so having those you know, possibly uncomfortable conversations, but doing it with a respectful approach can also kind of remove the stigma, the shame. You know, when I worked in Washington Heights, I had patients who were HIV positive who sought care in Chinatown because they didn't want anyone to know they were getting the care. And so we have to understand that there are so many complexities that our patients go through, and we always want to be respectful for that. And that's where the culture comes in, because we can understand what they mean. I had a patient one time who her husband would go to the DR during the winter. He didn't like, cold in New York. And when he came back, she had a discharge and she never had before. And so she was like, why would I need to be tested for anything? Because it's my husband. And so these are the complexities that we have to also make sure our patients are aware, and also kind of develop pathways for screening that are without shame or stigma. So I want to jump into a conversation with Carlos right now. Carlos, you are a community health worker. Can you please kind of educate us on how you provide patients with agency and autonomy to navigate the stigmatization and linkage to care that so often can happen to our patients who have HIV or screened for HIV, and the complexities that are surrounding HIV care?
Yes, uh, so as a CSW, community health worker, well, I have the presentations, but also like in my own words, I would say that my experience working in the linkage to care in different agencies that I have been with, it has been very interesting, since I have approached to different community, and the best the best part that we can do is having the approach smoothly to the community based on the race, based on the knowledge, and also the background. Also, we have to be mindful about the education of the people of the community that we are going to do the intervention, because we have to understand that not everyone has the same level of educations, and we have to explain how this connection or this linkage is going to be working, who going to be seeing this patients specific for what they needed, because it's very important to give the all information as much as we can to our clients or patients at the moment that we have to navigate what a provider we are going to link them. I have the presentations. I can have assisted with the slides that responding your first questions, the previous ones about how we manage a patching experience. If we can uh, move to the next one, to next, please. Next, they're gonna be the next one. Sorry. that one. So this is based on the my experience that I have been facing in the community, how we have been navigate the patient experience in the healthcare, which is, I mentioned already, patient education, understanding the patients, improving communication, which is one of the best or the most important that we had to do it at the moment that we had to linkage our community to the medical provider. Following with the patients, that is also important that we have to follow and let the clients that we are there, that we have not forget about their need or their case that we have to link it then. Observing the patients and collecting patient feedback. That is very important that we have to be able to listen how they feel, how they want to be treated, how they're gonna be a management they're needed. So there is my approach that I have been doing. It also we have the ways to address the disparities among the based on ethnic and race, increase literacy with the patients. Also acknowledge about the races, because still, even though we are in the 2024, still races a lot in some providers, based most on sexual orientation to all of the race. Training medical professional. This is other important that we as provider, we can do trained how properly address based on the sexual orientation, on the also the background of the clients. There is other factors that we have to look like social factors, improve data system, to be mindful or be aware about how many are in our community attending their healthcare based on the race. And also we have the strength patients provider relationship and community health worker, which is very important to have those services in our community. Oh, no, this part, no, not yet.
And based on like what Carlos has said and Dr. St. John, like with that patient, when I was meeting with her, she's like, Doctor, I want you to check everything. And I'm like, why do you want me to check everything? She had just come back from DER, because this is the predominant community I serve, right? And she's like, well, everything, I just don't feel right. And I just want to be sure. And then when talking to her, and she's very religious and she's older, right? Talking to her a little bit more, it turned out that she's like, well, can you check me for HIV? And I was grateful that she was just able to, after the nerves were put down, have the trust and me the respeto to see like, what is it, what's going on with her, and then to ask. And then from that, it took like a week and a half, but it was constant meeting and reducing the fears and concerns of the disease, and thinking about her education, and then also the barriers in the community of the stigma that she would face. And we had to navigate different ways to reduce that, and the racism she may face because of this new diagnosis, right, or discrimination. So it was really key, and we had patient navigators and community health workers are just so integral in terms of reducing that gap within our community.
Thank you both. I mean, sharing your experiences, this is how we have these conversations that can be difficult, but we also educate our fellow clinicians, our fellow providers, and this is how we have a sense of community. I always have to reflect back on kind of where we've come in terms of HIV care and also prevention and the availability of PrEP, and how some patients don't know there is availability for different kind of medications that are preventative. And so this is why we have to continue the conversation and keep talking. So I'm going to go into our next question, if that is okay with our panelists. Intersectionality calls for the consideration of how systems of oppression operating at multiple social, ecological levels create inequities within society and ultimately affect HIV prevention and treatment outcomes. How might clinicians and community health workers apply this consideration to the methods in which they deliver care? Maybe Carlos, you want to jump in first, or?
Hold on, because I was
If,
so
Well, while
oh,
you work on that,
hmm?
would you want to jump in?
yeah, I can jump in. So it's very complex in terms of one thing I guess I'll bring up is like the political climate right now and the things in terms of the rulings that are occurring and the leaders that we have, it's really impacting our community. And it creates more fear. And then if, let's say in terms of immigration status, someone may be fearful of even expressing that component to seek care or even getting care. So there's so many dynamics that we have to think about and be sensitive to when we're meeting the patients and talking to them and trying to tease out and build trust. And I think not making assumptions. If we make assumptions, we're already on the wrong foot. Is learning that individual, building trust. And if that individual is, let's say, not responsive to us or mean, it may be that they really had a bad experience with the healthcare system or our US infrastructure, right? So teasing that out is, I think, key in terms of making that connection in terms of prevention and diagnosis. And then lastly, I think also to think about is I practice in the North. It's easier. There's different restrictions. There's places where I can refer patients in the communities. But in the South or in the rural aspect, there may be more barriers. And then, as Carlos mentioned, the gender aspect in terms of discrimination, even another. So I think it's about education, policy, and pushing as professional organizations and us as advocates that we can do better for our community and our people.
I completely agree. And I think one of the things that you both have been talking about is the bedrock of any medical care is respect, but also trust. If that's not the bedrock, then we can't build a foundation on top of it. And I think one of the things that Carlos brought up, and I know we went quick with your slides, and I hope we can go back to them, is the social determinants of health. So if our patients don't have healthcare literacy or education, they can't understand what we're saying to them. If they don't have insurance, if they have unstable housing, there's so many non-medical factors that influence outcomes. And, we categorize that as social determinants of health, but these all are impactful when we talk about outcomes. And so there is so many ways that we want to develop pathways to our patients and including the importance of our community health workers, because they are kind of our front line on getting the patients to see the providers, getting them into the offices, creating those bridges of trust that are so necessary so that we can care for our patients. But Carlos, I wanted to give you an opportunity for you to join in and kind of hear what you have to say.
Sorry, I was mute. As a CSW, those barrier that we had faces or how we work in the community is it, doing the education or if we have the patients who has limited access to a provider, we first meet with them and then we provide the counseling and then sorry well
Should
sorry
we go back to your presentation, Carlos? Because I think it's very
is
interesting. in terms of what you do. And so just explain it to us. You know, you're here amongst friends, and we want to learn from you as well because you are so important in this kind of equation of us taking care of our patients. So please just jump in there, Carlos.
Okay. The presentation, it is, if you take from the first slide, you're gonna, because that is the like part of the part of the last that is the last part of the presentation.
So perhaps we can prompt the slides from the beginning to see where Carlos would like us to land on. Can we start from the beginning, please? Thank you. All right.
So, okay, thank you. That is the barrier that, okay.
Can we go back to the barrier slide, please? Thank you.
Thank you. So the barrier that we have up as CSW, we have to face a month are the financial difficult, as the transportation, the health literacy, stigma, health system challenges, and the discrimination, privacy concern. As a nonprofit CSW provider, we had to face all that and help to our clients to work in a plan in order to develop the healthcare. And if we had to support in all those needed, we will move from there and to provide the services. Also, the other barrier that we have identified in the community, if they have a chronic poverty, if they don't have if they are very low income, structural inequity, also life stress, dependent of the job, marital status, or also economic, the social isolations when they don't have a family, they don't have a friend, they don't have no one or relative to talk about their problems. Unstable or poor quality housing, maybe they are out of, they don't have a place to live, and mental health distress. We identify a lot of these issues or barriers in the community, especially here in New York, and we had to address all that. And drug substance abuse, that is a big challenge in the community. That is a very one of the most factor also that they put limit to the HIV care. Those are the most challenges that we identify in the community.
Another I'll add is that it's a spiritual distress. I teach more about this because it's teaching others in terms of there is a diagnosis. And the first thing, you know, I heard is, why did God do this to me? And this disconnection and their religious belief. And then trying to help them tackle that it wasn't of anything that they did wrong, and tackling that barrier and providing sometimes even referral to like chaplaincy to help them through that aspect in terms of spiritual distress while they're tackling the information of the diagnosis and also being accepting of the treatment. So those, I think, are definitely like so many things that we also have to think about for the patient too, that sometimes we don't think that physicians should do. But it's so important to take care of the whole entire individual.
You know, our community faces so many barriers to care. And I think that what you both did just shed a light on all of the complexities, almost like a jungle of madness that you have to go through to get the care that you so rightly deserve. But I want to take this moment to introduce Dr. Cantos. Thank you so much for joining us. It is such an honor to virtually meet you, professor at Emory University and also Division of Infectious Disease. Dr. Cantos, I want to just give you the floor right now to just briefly introduce yourself and just again, thank you for joining us today. I know you are extremely busy, so we're so happy to have your voice to the conversation.
Hi, everyone. Apologies for coming at 1:30. I had another meeting. that just ended. So yes, my name is Valeria Cantos, and I am at the Division of Infectious Diseases at Emory University in Atlanta. And what I do, I provide direct care to people living with HIV at our Ponce de Leon Center that provides care for people living with HIV around Atlanta and even Georgia. We have over 8,000 patients in our clinic, and about those 10% are Latinos or Hispanics. This population is mostly monolingual, Spanish speaking. The overwhelming majority of them do not have private health insurance, so they're all under ADAP and receive the funds of the Ryan White Clinic to support their care. So that's my clinical work, and then my research work, I do implementation sciences studies focused on how do we increase accessibility and quality of care for HIV prevention, meaning pre-exposure prophylaxis for Latino, gay, and bisexual men. And then the last part of my job is I do clinical trials related to HIV prevention and STI prevention and treatment. At our site, we are committed to increasing representation of Latino participants in clinical trials, which means that there is a lot of work to be done behind the scenes to make sure that we are able to do so. So thank you for having me.
Wow, that's incredible, all the kind of multifacets of the things that you do. So we are happy to have your hands in a lot of those things, especially there in Georgia. I just want to kind of give you the floor to answer some questions that we already kind of went over in terms of the challenges for cultural congruency in care, and like how do you tackle the shame, the stigma that surrounds HIV and those getting access to care. And just lastly, also, if you could address kind of having a platform for autonomy for your patients when seeking care or even preventative care.
Thank you. So the first one, the barriers to access to care, is something that I live and breathe every single day. In a state like Georgia, which is a new-ish receiving environment for Latino immigrants. So unlike places like California or Texas or New York, the immigration of Latino individuals started around the 90s, around the Olympics. And it's because they needed people to help with construction, infrastructure, restaurants, hotels, etc. So the overall healthcare system is not prepared and has not stepped up their accessibility of healthcare services to meet the needs of the population. There's also, as you may know, a lack of social and state-based support for these communities, which have left them, to basically fend by themselves. Luckily, there are clinics such as my clinic that are Ryan White funded, that can provide HIV care and HIV prevention care to people regardless of their insurance status and regardless of their immigration documentation status. That said, this does not mean that even our clinic is 100% accessible to our communities. And what I mean by that is that, for example, even though healthcare system-wide there has been implementation of tablet-based interpreter in real time, and we have one in-person interpreter in our clinic for the whole clinic. That is helpful for clinical encounters, but those iPads or the interpreter, they're not there at the front desk, at the pharmacy, at the lab, at the phlebotomy. So, they depend on someone else who may be willing to translate for them or help them. So that is one one thing. So the lack of language concordance and language justice to provide care. And like I said, even though our clinic has, intentionally tried to improve this, there's a long way to go. And I can only, speak of where I work, but I can imagine that elsewhere, people face the same types of issues. I am very happy that there are some other community-based clinics, including some FQHCs in the Atlanta area, that are located in areas with very high Latino population, who have completely changed their structure to meet the needs of the community. Meaning, when you walk in, the person who greets you is Latina. When you schedule the appointment, everyone speaks Spanish. The nurses are Latino, the doctors are Latinos. And this is, it just takes work, but it's worth it. And then you were mentioning about the stigma in, representing a huge barrier to care and to prevention, and you're right. And this is not something that is exclusive to the Latino community. There are other minoritized, populations, or Black or African American community. They have this, same issue with stigma. But importantly, things that we can actually act upon, and that we as clinicians and policymakers have the power to do, is how do we change the social and structural barriers to access to care? And that, includes big things such as Medicaid expansion, and then, other things that are more manageable at the local, at every local clinic. For example, having in the waiting room all the documents that people need to fill, to have them in both languages. People, social workers who know how to go through the medication procurement system, for example, for injectable PrEP, for people who are undocumented or people who are uninsured. Those are things that we can do if we're really committing to meeting the needs of the community. I'm just going to stop there because I could talk about this for hours to end, and I don't want to bore you.
Listen, I think we can all listen for hours. I think what you're saying is so tangible and we get it. And, I think you bring a lens to things we don't think about, right? So when the patient is not in the clinic, right? When they go to the lab, when they go to radiology, when they go other places, and having that representation, right? And having someone that understands the culture, speaks the language. These are all the barriers that we tackle. So I'm going to jump again into the questions. So I just want to talk about, we talked about social determinants of health and how that can affect an individual's probability of acquiring an infectious disease such as HIV through influences such as behavior, limited access to preventative measures, limited access to healthcare professionals, and testing sites. Using your understanding of these social determinants of health, how do we navigate, right? You gave us a few suggestions, but how do we navigate these challenges for ourselves as, working on the provider side, right? But also for our patients. How do we kind of steer that navigation? Anyone can just jump in.
I think one way is, we've talked about politics and policies, and I think those are one of the many ways that we can navigate that. And it could be us as individuals or professional organizations, so we can impact what's going on locally in the community, like federally, state, and then locally, because they have implications. And then one thing that I thought was amazing in terms of the Latino Commission on AIDS is that they have several programming, right? And it's a national preventative programming and treatment in terms of to build education and reduce stigma. And one is tailored with community health workers going to the faith-based organizations and then providing education and material in that sense. And that, is meeting the patient or the individuals in their community, right? Understanding their educational aspect, and then also the other cultural or religious beliefs that they may have an implication in terms of them receiving treatment or preventative care. And the last thing I'm going to put out there, I think we have to change the language of like, let's opt out HIV. It's a one time. It should not be a one time. We already know minoritized groups are at higher risk. There's disparity. So let's do like pre-diabetes, right? We're going to do annual screenings based on your risk factors. And then depending on if you're normal, we may want to just do it every year, just to reduce the stigma of this. And then the other thing is we don't know what the other partners are doing, and we want to trust them, but we also need to try to take care of our patients and tackle this better.
Thank you. I think that's so important because we think about what has been done with hepatitis C, right? Now in New York, anytime you go to the emergency room, they offer you a hepatitis C screening. And why are we not necessarily doing that for HIV as well? Or making it a standard of care and doing annual screenings for it? We walked away from it because we had such advances in terms of HIV care and treatments. But I think we still have to understand it's still a public health crisis and that it should be addressed. Dr. Cantos, do you want to weigh in terms of what your thoughts are?
So if I understand the question correctly, is how do we, as providers or organizations, help navigate the communities to access care? Okay, so I think there are many ways that this could be done, and it includes, outside of the clinic, in the community, and then inside the clinic, and then like Lucy said, things that could be done at a larger scale. But then starting in the community, we here at Emory, we did our group did a campaign, an online social media campaign to raise awareness among Latino groups, focusing more on those who speak Spanish only, about, what is sexual health? What are the things that I can do? What is healthy about sexual health? So, like Lucy was saying, getting an HIV test, getting STI test, getting on PrEP, getting on PEP, getting on HIV treatment if you are someone living with HIV. So just to increase the general awareness that these services exist. And then we link those to a community-based peer navigator who would then say, okay, you know what these are now, but you don't know how to get there. Let me help you how to get there. And then so the social media campaign used, languages that are easily understood by the community, images of, regular, normal Latino people, including older people, younger people, married people, couples, all types of couples. And then the peer navigator himself was a, Mexican-born gay man who was living with HIV. And, we provide training for the navigator. And long story short, when you do things in a way that are culturally concordant and that address the needs of the people will come. Because it signifies that someone is thinking about them intentionally, and then hold on to that. We had a huge response to that. We were able to link many, many people to PrEP, PEP, HIV care for people who either were not aware of their diagnosis and then got tested and found out, and then we linked them to care, or people who knew they were living with HIV, but they just could not navigate the US healthcare system to link them to treatment. So that's one example. There are many others. In clinics, if we think about what is it that people need flexibility, people need transportation, people need telemedicine, people need, a low threshold, a low barrier to attain communication. They don't want to be waiting on hold for hours. They need someone to, have the patient portal in Spanish so they can easily use on their phone. So then these are examples that I'm bringing up that, some researchers and clinicians have tested. and they work. It's just, oh, and then the other thing that I wanted to bring up, a lot of us here are clinicians. We provide care, and we're often, for example, when I have to care for someone who, doesn't speak either English or Spanish, and I don't know the language that they speak, sometimes I get stressed, because that means, I am not able by myself as a physician to care for their needs, to all of the needs that they may have. So I think all of these strategies and interventions need institutional support. The bosses, the people in the C-suite, they need to be committed to help clinicians to provide the best care that they can for the patients. Without it, us as clinicians, with our humanity and our clinical knowledge, there's so far that we can get before we need assistance, a broad scale assistance.
I'm completely in agreement. I am in upstate New York, and after working the majority of my career in Washington Heights and New York City, and with my Dominican population, which reflects my own culture, I moved up to an area where we have a large population of people from Guatemala. And although we would think, again, our own kind of biases, thinks they would speak Spanish, they do not. And so there's over 22 indigenous languages of Guatemala, and there's 8 present in the community that I work in. And so we have no translation, and we have no opportunity to really communicate and connect with our patients aside from using a family member. And that is a barrier, and that's realistic. And so kind of thinking about the strategies that you just described in terms of telemedicine and peer community leaders and kind of those social media campaigns, those are some barriers that we exist. So we want to kind of change the game. But again, if we do not have institutional support, if we don't have buy-in from the stakeholders, sometimes it's a very difficult feat. So again, I commend everyone here from doing the work that they're doing. Carlos, I want to let you jump in and kind of give what your sense of what are strategies that can be used to navigate these challenges.
Yes. So from the experience that have been faces with these challenges about, as the doctor was talking about, the language barrier, we have been faces with people that are coming from the Caribbean, which they speak Creole. The way that we have been faces is doing the resources about all information that we had to give to provide our clients is doing the printed out material, educational material. Also, we had to reach other peers that they speak Creole specific for this target population, but also other languages or dialect. Also, we are implementing the device which is gonna be translated in a quick like translation way, because we don't want to lose the connections at the moment. Like for example, when we do the HIV testing, and we have a person who doesn't speak either English or Spanish, which are the 2 main languages in the office. We use Google translations, or we use any device, but that is also a barrier to do the counseling and to have a better understanding the needed, or how the risk factor we are going to be addressing based on they express. But we try as much as we can to cover all those to cover the barrier, which is the language. So the other way that we face that barriers is going to other doing resources to other providers which are in the community, like looking for providers that they speak this specific language or dialect. We try as much as we can to make confident our clients.
So I think we've talked a lot about the barriers, right? And we talked about strategies. So one of the ways that we want this webinar to be helpful to our fellow clinicians and providers is how can we help our other clinicians, what are some of the resources that you guys use or that you can kind of advise our providers to tap into to mobilize partnership opportunities in the HIV field to kind of solutions to the gap in care? Because I think that, hearing Dr. Cantos, what you're doing in Georgia is incredible, but, how can we get that widespread across the country? Because again, we have to we are challenged with language barriers, but also literacy barriers. Sometimes our patients can't read or write, right? And so we can develop these kind of strategies, but if they can't read it or if it's a language that they don't read, right? Those are barriers as well. So what kind of suggestions do you guys offer for other clinicians who may be facing the same plight in terms of getting that information out about HIV prevention and care and increasing accessibility for patients?
I think one thing that may be important is depending on where you're at, you may want to see what other community-based organizations or faith-based organizations are doing and partner with them, right? We can't do this alone. Valeria said that, Carlos, you have said that it's weird. It's a team-based care in the clinic and outside, really, to tackle these issues. The other thing I think about that we need to push the mark and advocate for too is AI, right? In terms of research, it should be in our clinics, in our community setting, and to really see in terms of how it could help us in terms of interpretation, translation, but to make sure it's accurate, right? Because there's many different dialects of Spanish or other languages that we may have. And hopefully, since there may not be enough interpreters or tablets around, that this may be a way to shape medicine so we can just provide language concordant care.
Thank you. Dr. Cantos?
I want to add something about about the barrier for when we had to when we had to like if we are gonna if we have patients or clients that is, for example, taking any specific medication, which is a very important about literacy, is let them know what is the specific information based on the need of the medicines. Maybe the doctor will know better than me, but it's so important to to speak with accuracies or the right name, like for example, if they are under HIV treatment, what is the name or what the components that this medicine is has, because I haven't met clients that when they come to me and I ask, are you under HIV treatment? Which treatment you were taking before coming to, like, for example, if they move from outside, from New York, and they go by the colors or by the how look like the bottle, which is not right to for them, like to just to know the color, which is very important to also know the name and the component of the medication, because it's gonna be better for us to help them. It's so important to educate in that part.
I completely agree. Thank you, Carlos. And Dr. Cantos, do you want to join in?
I think, I agree with what Lucy and Carlos have said. We need to know what community-based organizations are doing locally in our regions, because they usually offer direct services that clinics cannot provide. So, for example, here we collaborate. I partner with 2 local CBOs. One is called Latino Community Fund Georgia, and they, their scope of activities that they do for the Latino population is very broad, but they include things like voter registration. How do you connect them to health services, free legal advice, especially for migratory related issues. So these are things that, and other things like food markets and clothes and a bunch of other things. So I think linking up with those and knowing what services they offer and who to refer your patients to is helpful.
All right. Well, I am so grateful to all of our panelists today. They have helped us with such a fortitude of information. So just thank you all to all of our guest speakers for their time and expertise on today's topic, as well as our live audience for participating today. A recording of today's discussion will be added to the NHMA's YouTube page and website within a week. So please remember that resources on HIV prevention and treatment for both clinicians and patients are available for all of our membership and partners. These also can be found housed in our NHMA Health Hub, HispanicInformation.info, as well as NHMA website and the CDC Nexus site. The CDC now provides free self-test kits available, as well as that are delivered to your door at no additional cost. So I want to repeat that. The CDC provides free self-test kits that are available, and they can be mailed and delivered to your doorstep with no additional cost. So just see the website for other resources. And again, I want to thank everyone today for this very robust conversation and opportunity to educate our clinical partners, our colleagues, the audience, and just everyone on the importance of HIV prevention and care, and also strategies to address navigation and the challenges that exist, and that we must forge forth so that everyone gets equitable care. So thank you all.